All right, folks. Well, I'm really excited about this because I have a dear colleague and a friend, Dr. Sanam Loghavi, who is on today's podcast, Healthcare Unfiltered. She is going to dissect for us the pathology profession as an enigma. So that's really going to be very exciting. For all of you pathologists who are listening about this, I'm going to be challenging Dr. Loghavi a lot about what the pathologists do. She doesn't know that yet, though. So we'll see. So Sanam, welcome to Healthcare Unfiltered. I really appreciate you taking time of your schedule. I know how things busy are, and we are taping this actually towards the end of 2021. We are going to air it in probably late February 2022 for those of you who are listening. So let's start by quick introduction as to where you work, who you are, what you do day in and day out, and tell us who you are.
Hi, Chadi. Thank you so much for having me as a guest on Healthcare Unfiltered. I'm very excited to be here. So as you know, my name is Sanam Loghavi, and I am a hematopathologist / molecular pathologist. That's how I write it. So that's how I say it too. At MD Anderson in Houston, Texas. I did my residency in pathology at Cedars-Sinai in Los Angeles. And I came here, did a fellowship in surgical pathology, hematopathology, and molecular pathology at MD Anderson, and then stayed on as staff. And I've been on staff since 2015. The bulk of my practice, obviously, is Empath, focused on myeloid neoplasms, and the molecular that relates to Empath and molecular and myeloid neoplasms.
So, Sanam, today's podcast, though, is a little bit unique because we want to try to make sure that listeners, whether they are students in medical school, residents, whether they are the lay public and the general folks who listen to this show, understand what pathology is. But we're going to take them through that through your lens as somebody who went to school and so on. So you went to school where?
I went to school in Iran, in Tehran, Iran. I graduated from a school called Azad University in Tehran. So our medical school system is a little bit different. We go to medical school directly from high school. So I was in a 6-year medical school program and then graduated medical school in Iran. Came here pretty much right after I graduated, and then worked for 1.5 years at a research lab at Stanford at Eugene Butcher's lab. He's an immunologist. Did some research there, and then applied to residency, and then got into residency and the fellowship track and the clinical track.
I went to medical school in Syria, which is very similar to Iran as well. It's a 6-year after high school. So during medical school, were you exposed to pathology as a possibility? Did you even know what pathology is? Like, what was your understanding as you were applying for residency? How much did you know about pathology to apply for it?
Actually, you know what? I have to tell you, my understanding of pathology was very limited. So our exposure in Iran, I think similar to what it is here in medical school, was very limited. We had, as part of our basic science courses, we had a histology course where we would, go look at these like ancient slides that were probably at the lab for like 50 years or what. And, I think that was part of the basic science course. And then we got pathology, again, either as part of basic science or right before our clinical rotations. But again, very, very limited, completely unlike what, pathology practice is. It was in a very protected environment in a lab. You would go look at the slides, and then the exam was basically, we would memorize like what the actual slides looked like, as opposed to learning the histology. We'd memorize what those looked like to get a good score on the exam. And the way I was actually exposed to pathology was completely outside of my medical school. It's because my best friend's dad was a pathologist. And it's interesting because his practice in Iran, he had a private lab. His practice is a world different from what I actually do now because, first of all, because of the way pathology has changed throughout the years. And then obviously, being in an academic setting in a large cancer center is nothing like having a private lab of your own. But I think that was my exposure, and that's what got me interested in pathology in the first place.
You know what's what's interesting, Sanam, is that you mentioned that the medical students, even here, they don't get exposed to pathology. And when I was in medical school, you're absolutely correct. I would go look at these slides and I would have to remember the colors. Like, okay, this looks like
Yeah.
it's a bright pink. It's probably the thyroid. I have to remember. I had no idea what I was looking at. So how, I mean, how do students can make a decision what they want to do if they don't have that exposure? And is it really a curriculum issue, or do you think it's like an afterthought specialty?
I think it's both. I think it's a curriculum issue because, when you don't have exposure to something, and I think, there are preconceived notions of what pathology is about. And I think when people imagine a pathologist, they imagine, someone sitting in a dark room looking at a microscope all day with no exposure to anybody, or, no exposure to patients. And we can talk about that. There are specialties in pathology that have plenty of patient exposure if that's something that, you're interested in. And then the other thing is autopsy, right? People think of pathologists and they think of, the guy in CSI that does the autopsies. But it's really so much broader than that. And I think one of the things that, I think you could say this about a lot of specialties in medicine in general. But I think with pathology, it's like really pronounced how you can tailor your practice to your interests and to your, to what you actually enjoy doing. If you love doing research, you can have a career that's essentially focused on research with very little clinical, work. If you like doing clinical work, if you like interacting with patients, you can be a blood banker. You can do cytology and do procedures on patients. If you like, even between the subspecialties in pathology, you can go all the way from autopsy to being a molecular pathologist that essentially does, all molecular sequencing based studies, heavily focused on research. So I think it's very different. And I think there's not enough time in at least the way the curricula are built right now for students to get exposure to all of these different areas. And I think one of the things that is, there's a stereotype for a pathologist, right? People imagine this introverted, person that doesn't like to interact with anyone. And I think that's certainly, it may be, we may have some people like that in pathology, but that's definitely not, not the normal routine pathologist you're going to come across, at least nowadays, I think. So,
Introvert, extrovert is not specific to one specialty or another, but we're going to go over these different ones, different specialties. But I guess if I go back to you, if you did not have exposure to, you said your friend's dad had a pathology lab. Do you think that played a role in making you want to apply to pathology?
I think it certainly played a role, although I think, what I imagined from seeing him practice pathology was completely different from what my actual, my career turned out to be. Not necessarily in a bad way or a good way, but it was just completely different. And actually, I can tell you that even when I started my residency in 2008, the way people practiced pathology back then was completely different from what it is now, even. I think
we're going to talk about that. Don't spill the beans yet, but yeah, go ahead.
Okay, sure. And the other thing I want to say, I think, one thing I want to tell medical students or, people considering pathology, I think one of the difficult things about pathology is, I was telling you, I actually would memorize, I'd look at a slide, I'd look at the gross image of the slide and say, the one that looks like a rabbit was a liver. The one that looks like, because it is so difficult to grasp the concept. It's almost like a foreign language when you first start. It's like you're trying to learn something that is completely foreign to you. And I think that throws some people off, because they think, I'm never going to be able to do this. This is difficult. It's much easier to at least in the beginning, to understand concepts in internal medicine or understand concepts in surgery because you have more exposure and at least people are, speaking the same language. But I think, there's a point in pathology residency and everybody tells you this, but it has to happen to you for you to believe it. I think it happens sometime during your third year when things actually start making sense. You look at slides and you actually get it.
So we're going to talk about the residency. You started the residency in 2008. Residency is 3 years, 4 years?
4 years.
4 years.
APCP is 4 years. So if you want to do exclusively AP or exclusively CP, there are 3-year programs, but the majority of the programs in the country now offer APCP tracks.
And for those who are listening, AP is anatomic pathology.
And CP is clinical pathology.
So what do they actually teach you? How is the residency structured? You come in, I presume you still have no idea how, look at slides.
100%.
So, it's just like, I'm pretty intimidated how that actually looks like. So take us through the curriculum of residency and what do you actually have to go through to get to that comfort zone in year 3?
So I think, different programs are structured differently. And, I obviously don't have detailed information on every program in the country, but I think one of the things that is shared is, the concept of double scoping, or, you look at the cases with your attending at the same time. So how most people do it, I would say, is, first of all, you get thrown in, from day one, they give you cases and they're like, look up the histories, write up the reports, do what you can. And you look up, there are reports from your attending in the computer that you can go look up. A lot of it is basically like looking at how your attending does things and learning from them. So you look at the cases, obviously you have no idea what you're looking at, but you try to, make your best guess at what you think the diagnosis is. And obviously there are books, there's now plenty of online resources that you can use to teach you basic histology, what normal can look like and what's abnormal. And then you preview the case. You usually have a day or two, depending on the cycle, on the turnaround cycle of the program, to look at the case. And then you take the case to your attending and you look at it together. You may have been completely wrong. They point it out to you, they teach you things, or you actually may have been right. You get a pat on the back and you're like, awesome job. So a lot of it is from double scoping, but I think the way you learn the most is just looking at a lot of cases. It's just like anything else. I view, I think it was The Tipping Point, Malcolm Gladwell's book. I don't remember if it was The Tipping Point or some other book where he refers to the 10,000 hour, for you to master something, you have to do it at least for 10,000 hours.
Boy.
And I think that's very true for pathology. So the more you see, things start jumping out at you. And it's just, a lot of it is pattern recognition, right? But I think, in my mind, what separates amazing pathologists from, good pathologists is that it's not necessarily just the visual skills or the pattern recognition, is that I think the really exceptional pathologists you see are the ones that are also good clinicians. They actually do the clinical pathologic correlation themselves. So I think for sure, people talk about having the eye. That is in and of itself a talent, but a lot of it is also about just like putting the whole picture together, right? Using the clinical information that you have in formulating a diagnosis and informing, helping your clinicians and guiding them throughout the process.
So do they give you like a lot of courses into the different stains and they is this something that part of the curriculum, this is when you use Congo Red, this is what Congo Red is? Is this part of the teaching?
No, most of it is not. So, you get exposed to the different, you basically get, like I said, you get thrown into the general practice of your department. So you essentially learn by doing, right? You see your attending orders a Congo Red stain for, amyloid, and then you go look it up. And, obviously if you ask people, they tell you about it, but it's not like they have like specific set classes that teach you what the different stains are. You essentially learn by doing it. You learn the IHCs, you memorize the CDs, the CD markers by practicing, by seeing a lot of cases. It's all, you're just exposed to it's just like radiology. I guess it's not even like radiology, because I think radiologists take some physics courses and basic courses like that. we really don't. You get some histology training. There's always, like, in the beginning, there are some didactic lectures that different attendings do. But it's, I would say that for the most part, at least as far as I'm aware, it's not a structured training where they tell you, oh, the H&E stain is composed of these chemicals, and this is, how the reaction. It doesn't work like that. You essentially just get thrown in and you learn on the job.
Do you have to learn how to cut slides?
You do. So one of the things I miss the most about, because I rarely do surgical pathology anymore, I actually don't do it at all, is doing frozen sections. So at an institution like ours.
What is a frozen section for listeners?
Okay, so a frozen section is when you have to give an immediate diagnosis on a piece of tissue while the patient is still in surgery, right? Because the surgeon wants to make a decision based on your diagnosis. Let's say if they're doing a Whipple, right, for a pancreatic adenocarcinoma, and they see a nodule in the liver, they're going to take that nodule and give it to you. And if that's metastatic adenocarcinoma, they're going to abort the Whipple. They're not going to do the Whipple, as opposed to if it's an adenoma in the liver, they're going to continue. So sometimes the stakes are very high. And sometimes you do a frozen section just to reassure the patient that they got lesional tissue. And that's what happens most in Empath. Let's say they're doing a biopsy, the patient has a retroorbital mass, and the surgeon wants to know that they actually got lesional tissue. So they'll call you and they say, can you look at this tissue? You look at the, we have rapid stains that we do. And so for that practice and for doing frozen sections, especially in smaller programs, and a lot of it is, basically to ensure that the residents are trained well. The residents are the people that are cutting the tissue and making the frozen sections. I think, at a practice like ours at MD Anderson, I know our Surg Path, we don't have residents, we only have fellows. But I know they don't cut tissue because the volume here is just insane. So we have, technicians that help cut the tissue, and the fellows are just looking at the slides. But in some of the smaller practices, including, where I did residency, wasn't even that small, but we did our own frozen section. So we would cut our own tissue.
So how often, that's interesting. So how often do you make a mistake? And how often, I mean, I presume there's obviously an element where, so the frozen section is clearly different than the full pathological diagnosis. What do you do differently? You do quick stains and you have to, on the spot, the surgeon is in the operating room, and he give you this, and it's like, I need diagnosis within like 30 minutes because I got to decide what or not. This can't
actually 30 minutes is they're not that patient, and they won't wait 30 minutes.
This can't be error free though. It must be like some, right?
It's not error free, and I will say that some diagnoses are more prone to error than others. But I think, both the pathologists and the surgeons recognize the limitations, right? So I think, let's say if you're making nobody makes a diagnosis of lymphoma or subtypes lymphoma on a frozen section, because, in order to do that, you need additional studies, including IHC profiling. And for that, you need to fix the tissue overnight. It gets embedded in paraffin. Later on, you cut the sections. First of all, you have better morphology. With frozen sections, you compromise the morphology because you don't fix the tissue appropriately. But still, most of our frozen sections are actually margins and nodes, right? So for margins, the surgeon wants to make sure that they got an adequate margin around the lesional tissue. And so they'll give you, let's say, a piece of oral mucosa, and they say, is it cancer or is it cancer-free? So that's, not too hard to do for the most part. Let's say, unless you're dealing with a well-differentiated or squamous carcinoma. For the most part, it's not that hard to do. Or they'll give you a node, they want to know, they'll give you a sentinel node, lymph node in a patient that has breast cancer. If you see metastatic tumor, they're going to do a full lymph node dissection. So again, that's not very hard unless you're looking for isolated tumor cells. But there are instances where we call a node negative, and then the next day on deeper sections, it turns out that there is actually tumor. It's not that the pathologist made a mistake. it's inherent to the process, right? There is some error that is inherent to the process. And I think when both parties, both the pathologist and the surgeon, understand these inherent limitations, it's fine. And they can make informed decisions. But sometimes, the mistakes happen, obviously. But, fortunately, it's not very frequent.
So then you go through residency, and during residency, do you need, well, first of all, yeah, I mean, how many subspecialties within pathology there are? And the reason I ask is because within oncology, obviously, as you know, I joke with people, I say, you're going to be specialized in tumors of the right kidney as opposed to, because, I mean, sometimes it's embarrassment of the riches. You can't be always that subspecialized. But I guess my question is, there are two career paths. One is general pathologist, I presume, where you don't need to do subspecialty, and one is subspecialty. Maybe I'm wrong, but tell us through, you get year 3, year 4, and what are the options in terms of deciding where you're going to go career-wise after residency?
Sure. So I will say for the most part, that is right. But with the caveat that even if you want to be a general pathologist, surgical pathologist, almost nobody is, even smaller private practices are not hiring anyone right out of residency. They want you to do a surgical pathology fellowship. And I think that goes back to historic reasons, because pathology used to be a 5-year residency. And I really think that you do need that 5th year to focus on, even if you want to do general surge path, to focus on, fine-tuning your skills. But yes, I think, in the academic setting, you rarely ever see general surgical pathologists anymore. It just doesn't exist, because most academic centers are super subspecialized now. In the community setting, you still do have surgical pathologists, which in my opinion is actually much harder than being a specialist, because you have to know so much, right? I mean, I think the depth of what you have to know is not as much, but you still have to know so much, and you have to know, how to triage the cases, when to consult a specialist. I think hempath and dermpath are the type of cases that get sent out the most, just because they're either difficult or complicated. They get sent out by surgical pathologists. But, I have friends that I did residency with that are now doing private practice, general surge path. And then you have the academic or subspecialty pathway. And even in private practice, I think, most hematopathologists are subspecialized and most dermatopathologists are subspecialized by training. And then,
so
for that.
That's an extra, so that's, you can do that during the 4th year?
No, that's extra training. So almost everybody in pathology does fellowship. Nobody gets a job straight out of residency.
Even if you do private practice,
yes,
everybody does a fellowship. So I finished 4 years.
I would say 99.9% of people.
So I finished 4 years, then I need to do a fellowship. My options of fellowships are hematopath, dermatopath, surgical path. What else?
Oh, many more. So cytopathology, bone and soft tissue, lung, breast, GI, blood banking, autopsy, molecular. I'm sure there are more that I'm, GU, kidney, prostate, bladder. Let's see, what else? Did we say hempath?
So you would apply to, this is like an extra year or 2 years.
Yes.
Where you apply to a different program or the same program.
Yes.
To do that.
Yes, absolutely. There's a fellowship. So our fellowship programs are not yet, I think most internal medicine fellowships have ERAS and they go through the match. We don't have a match for pathology fellowship, at least yet. It's still free for all. But yeah, there's a separate application process. You have to apply again, go through training. And obviously, there are places that are known, that are better known for certain subspecialties. And it gets a little bit more competitive. There are subspecialties that are more competitive, mostly because they have lucrative job options or they have better job markets. but I think all specialties, and I always say this to our trainees, and we don't have residents, but we have fellows, and I tell them, I think the best thing you can do for yourself is just to choose the type of practice, or if you're applying for fellowships, is choose what you like. Because if you like something, the chances that you're going to be good at it are much higher. Don't choose based on the money or the job market, because those things change.
Which one
and
is
if
the
you're
most lucrative? Which one is the
derm
most?
path, derm path.
Derm path.
Derm path is the most lucrative. So I can tell you that I'm not going to name any names, but because the people in the path community know this, but there are academic institutions where the dermatopathologist in that institution is the second highest paid person after the football coach.
No way. Wow.
So imagine that. Yeah.
Why is that though? Why? I mean, because usually you pay based on how much revenue you can bring.
Right, because of 88305. So 88305 is a CPT code. It's a biopsy CPT code. So, a dermatopathologist can look at 200 cases a day, because, the number of cases they can look at is much higher.
I see.
And so, as opposed to, let's say, a breast case with margins,
Sure.
one case can take an entire day, and it's an 88307. So, it's not that different. So you're essentially charging more.
Interesting. So for those of you pathologists in residence who are listening, this is the one to go to, I guess. So what got you into Hempath? What made you decide to apply for a fellowship in Hempath? And I think you did that at MD Anderson, you said?
I did. So yeah, this may be a repetitive story for some of your listeners if they're path trainees, because we talked about this on our podcast once. But I'll tell you the story. It's an interesting one. So because I like expensive shoes, so I wanted to do derm path.
I'm not somehow I'm not shocked about this, Sanam.
What am I gonna say?
But you know what? Before you tell me about the shoes, I always like to plug in what my guests are doing on the side. Maybe you want to say, you said about your podcast, the Path Pod.
Yes, yeah, we have Path Pod. So we have, so this is a podcast that Michael Arnold, Christina Arnold, Kamran Mirza, Sarah Jang, myself, and Andrew Belizzi. I hope I'm not missing anyone. So we have different themes. So Michael Arnold, myself, and Andrew have an IHC podcast where we talk about, immunohistochemical stains and different tumor types, their applications. It's mostly an educational podcast, but it's part of the PathPod series.
So you said you love expensive shoes, and again, I'm not surprised. So that led you to want to do derm path.
Derm path, of course. No, I think, well, obviously, the lucrative, and then it's, because it's the most lucrative, it's the most competitive to get. And I think, that it was kind of a challenge for me. And my residency didn't have a derm path fellowship. So I applied. I did my research in derm path. I had a couple of US CAP posters and projects. I went to the ASDP meeting which is the American Society of Dermatopathology meeting. And I think it was actually in Atlanta that I went to that meeting. And, I played all of my cards, right? But again, we didn't have an internal fellowship program. So I was applying to programs where I had internal competitors, right? So I was already kind of at a disadvantage. I did an away rotation at UCSF, and I did an away rotation at Beth Israel. And then I applied, and I didn't get a position until very, very late in the application process. I actually at the end ended getting a position at South Carolina, which I turned down for this Hempath fellowship. And I'll tell you how that happened. So I was on my Hempath rotation in residency, and my attending, who I absolutely adored, I loved. Unfortunately, she's passed away, but she was young. She passed away young. She had brain meningioma. So I was on my Hempath rotation at the time when I got, my rejection, like my final rejection from Beth Israel, where I had done a rotation. I was devastated. I was crying, hysterical, being a complete, Middle Eastern. I was just like throwing that. So she came to me, she's like, what's going on? What happened? And I said, they didn't take me. It's awful. I don't know what to do. My life is over. My life is ruined. It was like dramatic. She's like, what are you talking about? Who cares about DermPath anyway? Do hempath. It's much better. I was like, I don't want to do hempath. I want to do DermPath. And she was like, trust me, do hempath. It's better. It has a better future. I said, yeah, but it's already December. Where am I going to get a hempath fellowship? And I had already signed up for a surge path fellowship at MD Anderson. And they actually rejected me I always tease now Dr. Prieto, who's the head of DermPath at MD Anderson. I always tease him and I say, you didn't take me, but in good spirit. I had tough competitors. So, and they didn't give me the spot. Memorial Sloan Kettering, I had applied. They didn't give me the spot. So she said, let me call Jeff Medeiros. And Jeff Medeiros is actually my boss now. He's the head of hempath here. Actually, he sits right next to me. He's probably hearing me now. And she picked up the phone, she Googled his name, picked up the phone, and he was her program director and her mentor back when they were both in California. She picks up the phone, she's like, hi, Jeff, how are you doing? And she's like, Dr. Medeiros says, Rhonda, nice to hear from you. We haven't talked for a while. What's going on? And she says, I have this resident here. You have to take her. You have to take her for, 20, I don't know, it was like 2013. I was applying for 2013. And he says, it's really late in the process. We've already interviewed everybody. Let me talk to some people here. Let me talk to the program director and see what I can do. So then he calls within 2 hours. He took my number and application ID, whatever, he calls within 2 hours, and I had applied online on their portal. 2 hours, and says, if you want to come, you have to come tomorrow because we have a meeting. Yeah, I'm serious. He's like, we have a meeting at the end of this week where, we're voting. We've already interviewed everyone. It's very late in the process. It's just now or never. So my friend who was on the rotation with me, I had like a pile of cases this big to do. She's like, I'll do your cases. Just go do your interview. I think I paid $1,000 for that ticket. It was like a last minute ticket. I paid $1,000 as a resident.
Think how many shoes you could have gotten.
One.
Probably one.
Like the time that I like one. If I had done DermPath. So anyhow, I come to Houston. I have like zero confidence that I'm going to get this position, but she had already, put a call in there for me. And then I called Elvio Silva. I don't know, some pathologists, I'm sure GYN pathologists know him. He's like a legend in GYN pathology world. And he was a retired professor from MD Anderson who was working part-time at my residency program then. So I called him I remember I was sitting in the airplane and I called him from the airplane before we took off. And I said, please call Dr. Medeiros and put in a good word for me. I need to get this fellowship. And he said, okay, I'm going to call. So then he called, what can I say? I had some connections and, I got in the program. And I think that was the best thing that happened to me in my professional life. It changed my career.
When this North Carolina then came up, like
South Carolina. No, so I had interviewed at the South Carolina place, but I hadn't heard back. And then I came here, I got the position, and then they emailed me or called me, I don't know, and said, we're going to take you if you want for the DermPath. But then I was like, MD Anderson versus South Carolina. I think I should go to MD Anderson.
But hempath, no shoes, DermPath.
Hempath is okay too. It's not too bad. Well, no, I'll tell you, hempath with a little bit of crypto on the side is not too bad.
That's perfect. That's really a wonderful story. So then you got into MD Anderson to do hempath. Is there to do a hempath. How many years is hempath fellowship?
Okay, so that's another story. So hempath fellowship at MD Anderson is 2 years because we really want to get people that want to pursue academic careers, right? So our first year is dedicated to clinical hempath, where you see a lot of cases, you rotate through the different services. And then the second year, you get a lot of off-service time to do research. And that's how, you'll see our fellows are like publication machines. And that's how they do it, is because during their second year, they focus on their projects. And, the curriculum is built to train academic hematopathologists. So I had signed up to do a 2-year hempath fellowship. But what happened with me is I got a little lucky. So the person that was supposed to be the molecular fellow the year I was going to be a second year Empath fellow, dropped out of the fellowship. And so that position became vacant. And I was actually going to do molecular as my third year of fellowship because I wanted to get a job here. And, I knew that the way to get a job here was to do the molecular fellowship. So when that person dropped out, it kind of worked out for me. I got to do my second year as a molecular fellowship. And so I did 1 year of Empath, 1 year of molecular, and then got the job.
So you had to do molecular, or this was an option, like you did this extra?
I think if I wanted to get the Empath job at MD Anderson, I had to do the molecular because they wanted someone that's able to do both Empath and molecular. That was what the position was. I'm just going to turn this light on because it's getting dark here. 1 minute.
So that's really fascinating. So then you started your attending career a few years back. And what do you actually do in terms of research as well as clinical? You see all Empath cases, because the vision of a lot of people who are listening is that you sit somewhere in a basement in a dark room. There's like a microscope. There's a microscope. Okay, it is not.
I do have a microscope, but I don't know. All right, let me show you.
It is not a basement for sure.
It's not a basement for sure. I don't know. How do I turn this around? Yeah. Okay. All right. So here is.
It's definitely not a basement for those.
Here's the view.
Yes,
you can't see it because it's light, but it's not a basement.
View.
So I'm actually on the 5th floor of the Zide building at MD Anderson. It's a pretty nice space.
By the way, whatever, you're going to get a significant increase of applicants after this podcast to pathology residency, and I'm going to take completely full credit.
You should. We'll see. Well, we'll give you a commission for.
I will get that. But tell us, what does a day in your life look like as a faculty?
Sure. So, well, first of all, let me start by saying that we have, I think, 36 or 37 hematophathologists in my department. Not one of us has the exact same practice type. So each of us, has essentially carved out a niche for ourselves and has tailored their practice to their interests and, their skills and their research focus. So for me, since I do both Empath and molecular, your audience doesn't know, but I'm also a biobanker for, I'm the director of the Leukemia Bank for ECOG Akron. So my practice is very, very different compared to everybody else in my department. But essentially, I have, service days on like MD Anderson service days, and those entail, me being on the bone marrow service. So we have two different bone marrow services. One is new leukemia service, where all new patients to MD Anderson, that get a bone marrow biopsy, there's one pathologist dedicated to that service that sees all of those bone marrows that day. And I do that once a month because, we have, like I said, 30 some faculty, so everybody does that once a month. And then we have different bone marrow follow-up services. And these are the patients that get, surveillance bone marrows. And as part of that, so right now, as you know, Empath is like a complex, the practice of Empath is a complex process of evaluating morphology in addition to a milieu of ancillary studies, right? So I look at the morphology of the bone marrow, and then I have the flow cytometry where I assess the bone marrow for measurable residual disease, if it's a acute myeloid leukemia case or an ALL case or a myeloma case. And then, so that's my bone marrow, follow-up bone marrow day. And then I have lymphoma days where, we have lymph node biopsies, different tissue biopsies that are suspected to be involved by lymphoma. And as part of our lymphoma days, we also run the ORs. So if there's a need for frozen section for tissue adequacy for Empath, we do that. And it's actually, I shouldn't say we run it. Mostly the fellows are the ones that are doing that. But if they have a question, we're always their back. And then I have a dedicated flow service day where we do subspecialized complex flow cases. That's another part of my practice, which essentially, and that's one of the good things. I'm just gonna put in this little thing for Empath is that, when you do flow and molecular, you can essentially now do your job from anywhere in the world. I can be sitting anywhere in the world and, can be doing my job.
Shopping.
I mean, well, no,
That may not work.
That may not work, but you can be, I have a home office that is just as nice as my work office, I can easily work from home on most of my days. And then my molecular practice is mostly NGS heme for hematologic malignancies and liquid biopsies. But then, obviously there are different molecular pathologists that focus on solid tumors. So it's even within molecular, you can subspecialize and, focus on different subspecialties. And then I mostly focus on myeloid malignancies for my research. And so I tend to want to be more on the myeloid service because it just jives better with my practice. But if I need to, I cover the lymphoma service as well.
That's really, it's really amazing how subspecialized things are. I want to, there are a couple of things I want to make sure I clarify. One, I want to take you out of the MD Anderson milieu, just because I think we all know that MD Anderson is very differently resourced than other institutions, right? I mean, there is no place in the world, to my knowledge, that have 36 hematopathologists.
Yes, that's accurate.
So my question is, in a regular practice, there are some academic hospitals, not your size, and there are community hospitals. What happens there? If somebody is having surgery or having a bone marrow biopsy at a community hospital, I guess, are they subspecialized enough where the patients are going to get proper diagnosis of lymphoid malignancies, myeloid malignancies? I mean, it's in oncology, there is a general oncologist that still exists, and they're subspecialized, and oftentimes it's community versus academic. But what you're telling me is that even in community hospitals, these are subspecialized pathologists. So there is no general pathologist anymore?
I mean, there are general pathologists. So for the most part, I think Empath is a little bit, I would say Empath and bone and soft tissue and skin for the most part, because they're now so molecularly complex and the therapy depends so much on molecular characterization. A lot of, even if a general pathologist is looking at the bone marrow, it's very likely that they're going to say, this looks like acute myeloid leukemia, but we're going to send it out for further characterization. And they can always consult an outside pathologist. And we see, so our patients that come with a diagnosis from outside centers, they bring their pathology with them. So they bring the slides, they bring the reports. And for the most part, the outside reports are just as good. They're great. They may not be as detailed as the reports are here, but I mean, the quality is good. And I think one of the great things about being just a general surgical pathologist, they realize that, they're obviously you cannot be super specialized and up to date on all the details in every surgical pathology. But I think they know that limitation and they say, I can tell you that this is lymphoma. It's probably diffuse large B-cell lymphoma, but it needs to go to a subspecialist and be further characterized. And I think that's how, the practice is done nowadays. So even if it goes to a general pathologist first, it probably gets sent out. Unless it's a very, straightforward, I don't know, like follicular lymphoma, diffuse large B-cell lymphoma, something like that.
Sure. So in your Sanam, as you go through, you meet residents, fellows, other folks, like what do you think are the most common misconceptions about pathology as a specialty or as pathology as a training and residency? We talked to me and you about this a little bit when we met at ASH, but I want to try to, in your own words, where do you think there are some of misunderstandings, misconceptions that we would like to clarify to listeners?
Absolutely. So I think the number one is what we talked about, is the stereotype of the type of person that becomes a pathologist. And I think, that's a misconception. There are all sorts of people in
So
pathology.
give us an example of how pathologists could interact with patients, for example, because you're right. There's
Sure.
some of these stereotypes where people say, well, this person has went to pathology because they just don't want to talk to people, to patients.
That, if that's your reason, that's fine. Because you can, you can avoid patient care 100%, direct patient interaction by doing pathology. And I think, I wouldn't fault someone for not everybody has to directly interact with patients, right? So, but if you are the type of person that wants to interact with patients, you can do blood banking. So in most of the hospitals, blood bankers run the plasmapheresis facilities, right? So you can be a blood banker. You can do cytopathology. Cytopathologists do most of the superficial FNAs. They do procedures, they interact with patients all the time. There are now, actually, before the pandemic happened, Kamran Mirza and I had proposed a workshop to the Association for Pathology Chairs as a proposal for setting up path clinics where patients could come and actually, look at their slides with their pathologists. Obviously, there are limitations and hurdles to that because at this point it's uncompensated, right? It's not a reimbursable practice. But I think if it were something that, caught on as a practice where you could actually interact with your pathologist, that could be something. But there are subspecialties in pathology where you can interact with patients. And then I would say, I would encourage people to not forget about the interaction that you have on a daily basis with your colleagues, right? So you may not directly interact with the patient, but I'm constantly in contact with my leukemia colleagues. We're constantly emailing, texting, we don't call as much. It's just not, it doesn't suit our practice. This practice is crazy busy. So, but if they wanted to, or they can just, walk into my office, I can walk into their office. So if you're the type of person that likes to interact with people, you can certainly shape your practice that way.
So stereotyping that the pathologists don't like to talk to people is something that we'd like to clarify. It's not the case, although some people may want to do the specialty because of that. Other misconceptions that you may think about?
Other misconceptions is that, you're constantly just sitting at a microscope and looking at slides. And that is absolutely not the case. Absolutely not the case. You can again, form and shape your practice to your liking. And I think nowadays to me, it's almost like pathology is not it's not one specialty anymore. It's so diverse. You can have a full-on research career if you want with, a lab. You can be, if you love looking at slides every day, you can do that. Although I would say that in my opinion, the majority of pathology practices, at least at large academic centers, are going to be fully image-based within 5 to 10 years. So the microscope as we know it may not exist anymore in 10 years, although I love my microscope and I have a very hard time letting go of it.
That is very, very interesting. So Sanam, my last question to you, which I really think, hopefully it's fitting because we read about this a lot. And I'm curious your thoughts. There's a lot of lots of talk, I guess, and chatter about AI and pathology, the applicability of artificial intelligence into pathology with the idea that AI could enhance the diagnostic accuracy and minimize the errors of pathology. Now, I'll admit I have not researched the literature to even know what is the error rate, frankly, and how much AI will do that, nor do I, again, I think there's a lot out there. I don't know, any thoughts on that? Any opinions on that? I think that's really, because we hear a lot about it. Even on social media, there's so much on it.
I am a big proponent and fan of AI. And I will tell you, I think again, maybe in the older generation, there's that fear of artificial intelligence replacing us. But I really think that artificial intelligence is going to enhance our practice and is going to make us better pathologists. And I'll give you examples of why. There are, in my daily practice, there are repetitive, tedious tasks that I have to do that I think are probably, really well suited to AI algorithms. Let's say finding a mycobacterial organism on an AFB stain may take me 10 minutes on a slide. If you had an AI algorithm and applied it to that, did it in 30 seconds, I could spend that, those 10 minutes doing something that actually requires human intelligence, right? That is actually, so I think it'll save me a lot of time and I can use my time better. And there are certainly tasks that I think at this point are not amenable or suitable for AI. And a lot of that is putting complicated and complex pictures together. And I don't think that that's impossible to achieve maybe within, a few years, but at least at this point, I think, we can use AI for sure to enhance our practice. It's going to mean we're going to have to do a lot more during our workday. But I think that's okay. If we're efficient, if we're more efficient, why not? I'd love to help more patients with my time. If I can become more efficient and use my time better, maximize my time.
Yeah, that's great. I mean, so you do see the time in the next 5 years where there are certain AI algorithms that might actually help.
Absolutely, and we're doing that now. Actually, to give you an example, like quantification of immunohistochemical staining for some stains, like Ki67, can now be done, with AI algorithms much better than a human can actually count.
Yeah. So, what if you had the power of modifying or altering the curriculum of pathology residency? Where do you think the opportunities are during medical school curriculum and during pathology residency to change or to enhance in a way that really allows better exposure to the specialty?
Right. I think, there are limitations to the current system because I think, it's not because the system is flawed, but I think there are limitations that are inherent to the way we practice. I think I'm going to start with residency. I think one of the things I wish I had more in residency was autonomy. Because I think you're very, everything a pathology resident does is later reviewed and ultimately finalized by an attending in almost the majority of the programs that exist. And so I think, it's like you graduate today and you're a fellow that has never done anything independently, and then you're expected to just be full on independent the next day. And to me, that doesn't make a lot of sense, but I think, it's understandable because obviously the attendings are the ones that are ultimately responsible for anything that goes out, and that's a limitation of the system. But I think if we can afford to give our trainees more autonomy, that would be very helpful to their practice in the future. Now, for students, I would say if there are any students that are listening to this, make your own way. If you think you're interested in pathology, don't believe the stereotypes. Get yourself a rotation in pathology. Go spend a month in a pathology department and get exposure. Do an elective in pathology and see what it's really like and see what the real world practice of pathology is like.
That's fascinating. What questions I should have asked you that I may have not asked you and I needed to?
I mean, I think it's a given from speaking to me, but maybe that, whether or not I'm happy with the choice that I made. And, obviously I would tell you, yes.
You look happy. You look happy and you look like, you're enjoying yourself in the specialty. And I think
I love it.
Yeah, it seems like, it was the right choice for you, but I want to make sure that we cover all of the things. I think hopefully listeners know more about pathology now, know about the really complexity and the subspecialty of pathology and the amount of training that you go through and and what you actually do. And it's not really about just doing an autopsy on a show. It's, in fact, the last autopsy you did was probably 10 years ago.
The last autopsy I did, I think, was in 2011. Yes,
Yeah,
exactly 10 years ago.
10
Yeah.
years ago.
And they actually decreased the autopsy. So we had to do, before, when I graduated, we had to do 50 to be eligible to sit for the boards. I think now it's 30. They've reduced it to 30 just because it's, nobody does autopsies anymore. It's hard to get those numbers.
Yeah.
And, we would get those numbers at the medical examiner's office. But, I mean, yeah, autopsy is just, it's obviously a great part of pathology education because that's how you learn normal histology, because nobody's biopsying normal tissue, right? So you do autopsies and you see normal tissue. But I think, it's just like a very tiny fraction of what, and in fact, I didn't like doing autopsies at all. So.
Well, look, this was really, really, first of all, it was a lot of fun to record. And I think I learned a lot more about you, your career, but also about the specialty at large. And I really hope that listeners got a glimpse of what your life looks like as a pathologist, as well as what they can expect as they are applying for residency or fellowship and so on. And, there are a lot of controversies in pathology. So as you know, in Healthcare Unfiltered, I always like to do a couple of debates. So I'm going to pencil you in for a future debate pertaining to
Absolutely.
pathology. So get ready.
I'd love that. I'd love that. I love a good debate.
Thank you so much, Sanam.
Thank you for having me. Really, it was a pleasure. And, if any of your listeners or students that have questions about pathology, please feel free to reach out to me. I love to answer your questions, get you interested in the field.